Hey guys, I'm Dr. Chelsey Sandlin. I am the LSU Pediatric Residency Director for those of you who haven't met me yet, particularly our Med Peds residents. So we're so excited to have you become part of our LSU Pediatrics family. Today I'm going to talk to you about the policies and procedures at our LSU Pediatrics program. We'll cover things from evaluations and promotion criteria to professionalism to wellness and code gray, etc. So lots to cover. Some of these policies are going to be applicable to everyone, and some will be more applicable to just pediatric residents. I will cover the ones that apply to all first, and then I will transition to cover the pediatric specific ones so that those of you who are in combined programs can kind of stop listening. Precursor, please bear with me on this. It is not easy to present policies even face to face. So it is definitely not easy to present it over a video recording, but hey, at least you'll have this recorded in case you ever have questions. You can come back to it and get those questions answered. We will have a question and answer session live virtually on June 22nd with just me and you guys, and so we can clarify anything that you need clarified or talk about any other things that you may need to get to ask. Okay, so I'd like to start by showing you guys how to access our policy manual online so that you can recognize that you can see it any and all times at your leisure. So this is our LSU Pediatric Residency homepage. I would encourage you guys to save this as a favorite because lots of good accessible information here. Just click Residency, and then you'll click Resident Resources, Residency Manual, and here you can find our Policy and Procedure Manual for the Department of Pediatrics. So 55 beautiful pages of policies. Not really. If you enjoy reading policy manuals, then more power to you. But they are a necessity. And we're going to cover some of these, not all of these. So please read if you want any additional information. And then not everything that we have out there is in this policy manual, but it is on the chief website, and I'll sort of point those out. So now that you know where this is and how to access it, I'm going to transition and start talking about policies. I think it's best for me to pause and then pick back up with the first policy and do that to get through them all. So 1 second. Okay, so again, we're going to go through the policies that would apply to pediatric and combined residents first. And given that I'm recording this during a tropical storm, let's plan to cover our Code Gray policy first. So Code Gray is our policy that applies to when there are weather systems such as hurricanes that impact the hospital functioning and require the hospital to cut to minimum essential workers. Our residency program follows the same policy. We have our own separate Code Gray policy for our program in the event that the hospital initiates a Code Gray, and that is outlined here. Most importantly, the chief residents and I figure this all out and tell you what's happening. We keep you informed, we email you frequently, we have meetings about it. You will be in the know at all times. We have a Code Gray team. The makeup is here, and again, the chief residents and I work to develop the Code Gray team. Most importantly here, interns are not called to work during a Code Gray. They're not expected to be part of the team, and that's because most of these would occur in the July-August timeframe, during which it's not a beneficial use of resources to have our interns that are new stay in-house. So we do have our upper levels man the Code Gray team. However, your job as an intern will be such that you evacuate the city if a mandatory evacuation is called. You provide the chief residents your alternative phone numbers, email addresses, and an emergency contact so that we can get in touch with you at any time. And we'll be collecting that information from you when you onboard, but it's important to ensure that it's always up to date and accurate in our system. And then you have to check your email regularly for updates. A lot of times we lose cell service, etc., and email becomes a primary means of communication from the hospital and the institution and from us. The other important thing to know is that once the code gray is lifted, the residents that have been in-house in the hospital since it started will get to go home, will likely get to have time off, and a recovery team will come in place. And interns can be part of the recovery team. So you would know if you were going to be on the recovery team at the onset so that you could prepare for that. And as long as it was safe for you to get back to the hospital, back to the city, that would occur. These are rare occurrences, but we feel it's best to have a policy in mind. Of note, the last code gray that we had was in 2017 and was only 8 hours long. The one prior to that was 5 years before that, and did last about 2 to 3 days. So again, infrequent occurrences, but we think being prepared is important. Right. Going to hit pause. Okay, the next policy we'll talk about is our resident allotment policy, or our book money policy. This is not in our residency manual, so it's separate, but just want to outline how that works. Each resident gets $250 per year of an allotment to spend on books, medical equipment, board examinations, etc. And then residents in their final year of training receive $500 that year. Allotments have to be used by the end of May to have plenty of time for our coordinators to make that work. And then there are specific policies outlined to get reimbursed. And as you use that money, this is posted on the chief website and it will kind of walk you through those steps. So we will not dwell on this. I do want to outline that you can use your allotment to purchase supplies that support your professional or educational growth, including books, medical equipment, such as stethoscopes, conference attendance, licensing exams, application fees, etc. You may not use it to purchase clothing or supplies, and so scrubs, etc., you're not allowed to use it for that. However, the hospital does provide scrubs, 2 sets, as well as the department provides 2 white coats for you. So hopefully that isn't as much of an issue. If what you're spending costs more than $250, so for example, if you're applying for your step 3 exam and using this money to pay for that exam costs more than $250, you must come prepared to write a personal check to LSU to cover the difference. And again, this sort of goes through how to use those. Kelly can help as well. You can also use it for a meeting attendance. If you're presenting at a meeting, there's a separate way to go about that the department does support, and we can discuss that if you're presenting at a meeting. Okay, I'm going to try to pause and go on to the next procedure or policy. Okay, the next policy I want to show you guys is our social media policy. I feel like you got a lot of this training most likely during your time as a medical student, and it's more common to come in understanding what that looks like. However, we do have a policy for our program, and the background for the reasoning for that is outlined here. I just want to go over a few of the key guidelines. Number 1, we really discourage you from interacting with patients on social media, so meaning don't friend them or allow them to follow you. We would encourage you to set your privacy settings to prevent that from occurring. If they have like a team page or a page more like that you can follow, that's a group page, that's okay, but any sort of individualized interaction could lead to some liability issues. If they were to ask you a healthcare question and you actually didn't see it in time, and or you tried to answer something, it could cause some liability issues or get you into trouble. So we just preferred that you be careful about that and not friend patients. You likely know this already, but you cannot discuss, post pictures of, etc., anything that has to do with the patient. Even if you feel like you've removed identifying information, there is likely a way to identify that patient. So absolutely no discussing of patients on social media, including being careful of the pictures that you post from work. If you're posting pictures that were taken in the hospital, Please be sure there's no whiteboards with patient names written on them. There's no computer screens open that you can zoom in on and read patient information, no lists sitting there that people could zoom in on. Just be very mindful of that picture and what it shows. Please be careful in terms of what you post, whether it's complaining about work or a patient that was aggravating at work, which happens, and it's okay to vent and it's okay to do that in a phone call or in a personal conversation, but not over social media. It looks unprofessional, and as a physician, we really need to uphold our professional behaviors at all times, including on social media. So that's sort of what those two things said. I would caution you guys on friending others that you're on teams with that aren't residents. So for example, nurses, sometimes medical students and those sorts of things, because there's that power differential there, and you need to be careful about boundaries. As an example, I do not friend any nurses, nor do I friend any of my residents until they graduate. At that point in time, I will interact with them via social media, but not until they've officially left my program. So just be careful about that. And then we do have disciplinary actions in place that are reviewed by a committee if any violations occur. So be mindful of that. And any personal post must be viewed as your own and not representative of LSU or Children's Hospital. We do have an Instagram page for our residency program. We try and use it to highlight our residents and the fun things that we are doing. It's at LSU Peds is the handle. Eden is our Instagram administrator, and I have oversight. We do have ways for you guys to share stuff with her to get it posted, and we want to keep everyone involved in our site so that we can use it as a resource to attract students and to kind of show ourselves to our community. So we hope you'll join our page if you haven't, and then help us to make that special. Okay. Okay, this policy also would apply to all residents, and it has to do with tracking of your clinical and educational work hours, which is another fancy way of saying duty hours. You do have to track your duty hours on a 1-month basis. I would actually encourage you to download the New Innovations app, which would allow you to track it day to day in a much simpler fashion. Kelly and the chiefs will walk you through how to log those work hours, so that we can make sure we're abiding by all the rules. And it's important because we take this very seriously as a program. You can only work on average 80 hours per week, which is outlined here and is an ACGME policy. You must have 1 day off in 7 from all work, and you must not work more than 28 hours. For interns, the maximum you would ever work would be 16 hours in duration. You have no 28-hour calls, and the only 28-hour call we have in our program anymore is in the PICU rotation. Most of our overnight coverage is done by night shift and or night float. However, I do want to point out that this 80 hours per week, 1 day free in 7, is when averaged over a 4-week time frame. So for example, you may have 1 week of a 90-hour work week, 1 week of a 60-hour work week, then a 90, then a 60, and the average week hours worked per week would be 75. So you would still be abiding by that rule. Even if 1 or 2 of the weeks you worked above 80 hours, it is an average. Same thing with the 1 day off in 7. In a 4-week rotation, you must have 4 days off. Because we preserve weekends off in our program, those may not always occur 1 per week, but they will be when averaged over a 4-week time period. So keep that in mind. And again, we do take this very seriously. The on-call activities are outlined, and that really only occurs in the PICU, as we mentioned. And then in terms of fatigue mitigation, this is this is why we have what we call a jeopardy system. If a resident is sick or too tired to work, then we have a mechanism in place that the chiefs would call in a jeopardy resident. This is also why we have shifted everything to night shift and night float coverage, with the exception of PICU weekends, in an effort to ensure that we're monitoring fatigue and that we're limiting fatigue. And so we do pay attention to those and do some training about sleep health and hygiene during your residency. And then this just kind of goes through night float policies and all of that. Transitions and care, we have handoff in the morning, handoff at night, but then we also have an end of month handoff period, so we can be sure one team is safely handing over patients to the following team, and we take handoff seriously. I'll do a handoff training session with you guys in July, and we do evaluate your handoff on certain frequencies during your training. That's what that outlines there. And that's it. Okay. Okay, we're going to transition over to our leave policies. And this is the point where most likely the Med-Peds residents and the Peds-EM residents can sign out and not listen any further, as those are going to be governed by Dr. Lowe and Dr. McFarland more than me as the Peds program director. And then everything from this time forth will primarily be for the pediatric residents, with the exception of the evaluation process, which I will talk about right after the leave process. So if you want to kind of fast forward until you hear me talk about the evaluation process, that would be perfectly fine. So for leave, quickly, leave just means any time away from work. So whether that's a vacation, sick leave, maternity, etc., that's what the word leave applies to. Our official policy about job and fellowship interviews does state that there's no allocated time for job interviews. That is the school's policy. Therefore, that's what we list officially. However, we do have our own policy that you'll hear more about as you're a second and third year resident that does allow for some protected time for interviews outside of this. We do not post it in our manual, as it is somewhat off the record. However, we do allow some days for you to go and interview despite being at work. So just know that, and again, you'll hear more details as the time comes. In terms of vacation, all residents get vacation time. Interns receive 3 weeks of vacation, and then other resident levels receive 4 weeks of vacation. When you receive 4 weeks, we typically encourage you to take 1 week, 2 weeks, 1 week. And if residents need to chunk weeks together, it's difficult to do, but with enough advanced planning, we're willing to work with you. So for things like maternities, when you need to leave the country to visit family members, paternity leave, etc., we're willing to work with you and give you a little bit longer vacation time. So kind of keep that in mind. Sick leave. House officers get 14 days paid sick leave per year, meaning that if I am sick for 2 weeks in my intern year, that's okay. I will still have a paycheck. And anything beyond that may require some time off that's unpaid. However, the Board of Pediatrics requires 33 months of training for you to sit for your boards. So if you think about your vacation time of 3 weeks, 4 weeks, and 4 weeks, that leaves 1 week during your entire training for you to take sick time without having to pay it back at the end. Now, all residents, you guys will all receive 1 week of what we call payback at the end of your third year, meaning the last 7 days of your third year, we will not assign you to any rotations so that you can transition to fellowship or your careers, etc. So if you exceed your 7 days of sick leave during your training, the first 7 days of that could extend into your payback week. But beyond that, your official date on your diploma would be after June 30th, which in the end is not a big deal, and ultimately is something that, you know, we want to be sure you're getting the time off that you need. You would still graduate with your class, but your technical completion of residency would be a little later. We work with you on a case-by-case basis here. So if people become pregnant, they set up a meeting with me and Kelly, and we talk through the dates and the game plan. If someone is sick for an extended amount of time, etc., then we work through those on a case-by-case basis. Okay, so don't stress about this. I just want to put it out there so we all have heard it and we're all on the same page. Educational leave, we do give some time for conferences and things like that. Okay, so to go along with leave, next we'll talk about our wellness policy, and I'm going to pull that up in just a second. So going along with the leave policy, the sick leave technically stipulates that you must have personally an acute illness to take a sick day. The wellness day policy that is specific to our program that we created really recognizes that there are times when a resident may need time off for reasons other than an acute illness with fever and things like that. And so we have a policy in place where a resident can have a wellness day based on those circumstances. We do request that it's not abused and that it keeps in mind that the impact on your peers and the patients that you take care of. On paper, a wellness day is a sick day, and the resident must notify the chief resident of their need to take a wellness day and a brief explanation as to why. They do not have to know all of the specific details, but we need to make sure you're using the day for an appropriate reason. The chief also is important because they have to determine if a backup resident is needed to cover your clinical responsibilities. So some examples of wellness day reasoning: emotional exhaustion or being significantly overwhelmed to the point of it affecting your well-being and your ability to care for patients. To attend necessary healthcare appointments that would require you to have an entire day off. By the way, if you make an afternoon appointment and you're able to work that out with your team, then that's doable, or with your elective. We do encourage you, for the ones you schedule months in advance, please schedule them when you're not on an inpatient rotation and when you're on a more flexible rotation. But if there's something that comes up that's urgent or last minute, we are willing to work with you. But if you need a whole day to do some of those things, then you could use a wellness day. And then other life stressors that we could determine on a case-by-case basis. So like one example is maybe your child is sick and you cannot find childcare, then we are willing to work with you for that one day. But again, it can't be a frequent thing. Taking wellness days to leave for vacation early, to pack for vacation, to prepare or have a long weekend, to attend an event that you forgot to request off for, that's not an appropriate use of the wellness day. And unfortunately, this had to be added to the policy because it was abused several times around these scenarios. So you guys, everyone is an awesome pediatrician or will be an awesome pediatrician and is a great person. So use professionalism here and keep in mind your colleagues. You should still notify your team if you're going to be missing work prior to missing work. And again, the chief will determine if backup is needed. The chief will not tell me about the wellness day reason unless they feel your safety is at risk, or if you are using wellness days excessively or inappropriately. That is when I would get involved, and that's to protect your privacy. Okay, so I started this in 2017 when I became program director. It's really worked. People, for the most part, do not abuse it, but I feel like it gives us some extra flexibility to look out for your needs, and I'm really committed to this policy. Okay, so we're going to transition from leave into the evaluation process. Residents are evaluated in multiple fashions in a formal fashion. This is different than that kind of more informal feedback that you get verbally while on rotations, which we do encourage you to seek out at the end of each week or even more frequently than that. So, but in terms of more formal evaluations, we use resident evaluations of faculty, faculty evaluations of residents, peer evaluations of each other, nurse evaluations, patient satisfaction surveys, and occasional student evaluations. When residents evaluate faculty, it is anonymous. The faculty do not receive that evaluation until at least 5 evaluations have been completed on them to protect resident anonymity. Faculty's evaluations of residents are not anonymous. So if I evaluate you, you will know that it is from me. If you evaluate me, I will not know that it's from you, nor will I receive it until 4 other people have evaluated me. That way, if I only work with 2 residents during a month, I can't pinpoint that it's from one of those 2 residents. We prioritize resident anonymity, but open faculty names so that you're aware. Similarly, peer evaluations are anonymous and are batched in groups of 5 to prevent anyone from identifying the evaluator. Okay, so those evaluations, in addition to your learning plan, which you'll work on with me your first year and then your mentors your following years, are used by our clinical competency committee to complete a summative evaluation with you every 6 months. So the clinical competency committee is outlined here, who sits on it, etc. I'm on it as a non-voting member. The committee looks at all of these evaluations in addition to the members' input during the meeting to rate you on 21 different milestones every 6 months. So we rate all 45 residents on 21 milestones every 6 months and provide that information to you. And I will show you what those milestones look like and what that even means in case you haven't heard of that before. So we'll do that in just a second. If a resident is struggling or below average, or there's consistent trends in their evaluations that are poor, we do have this committee to help build improvement plans and action plans for growth, hoping to prevent a probationary period. And occasionally things have progressed to probationary periods, but we do our best to not get to that point. Okay. So as I mentioned, the pediatric milestones is really how our committee has to report you to the ACGME every 6 months. And we have built our evaluation tools of peers and faculty members, or from peers and faculty members, based upon this need. So this is like our master evaluation tool, and then depending on the rotation, they rate certain milestones. So for example, as a hospitalist, we rate about 15 of the 21 milestones because we work with you guys very closely in many domains. A peer may rate you in about 8 to 10 milestones, and then a subspecialist may rate you in 3 or 4. But the milestones encompass areas such as patient care, medical knowledge. These are the core competencies of residency training, practice-based learning and improvement, systems-based practice, interpersonal and communication skills, and professionalism. And you'll see these words over and over because it's really the domains that residents need to meet to be competent for graduation. And so just want to kind of show you guys an example. The milestone language is actually much wordier than this, but we've condensed the evaluation wording to be shorter so it's easier for everyone. But I want to show you guys how and what your ratings may look like. So kind of a scale at the top points out that, you know, a 2 may be like a late intern, early second year. A 1 may be an early intern, and it's not uncommon for you to get a 1 or 2 at the beginning. And then by your 3rd year, you'd be more likely a 3, 3.5, or a 4. And so you're going to most likely progress from a 1 to 2-ish to a 3 to 4-ish before you graduate. As you note, fellows and faculty typically would fall at a 5. And I'll kind of read one of these domains to show you what I mean by that. So for example, patient care 1, limited or irrelevant data gathering, limited ability to prioritize, versus recognizes pertinent data, which can be linked to broad categories. As you could imagine, this is really that student transitioning into intern role, versus advanced pattern recognition, information placed into specific diagnoses, which may be more your 2nd or 3rd year. Graduating 3rd years sometimes reach 4, recognizes patterns with ease for most common problems, versus honestly, I don't think I hit this until I was a 1st or 2nd year faculty, identifies subtle distinguishing findings and complex diagnoses. And so as you're completing your peer milestones on each other and your upper levels, keep this scale in mind. If you're giving everybody 5s, then you're overrating them. So really, interns should be getting 2s-ish to occasional 3s. Upper levels are likely getting 3-ish to occasional 4s. So just keep that in mind as you rate. Okay, and your evaluations are done in the new innovation system. Kelly and the chiefs will walk through that with you, but that's how you will complete your faculty evals and your peer evals, and that is where you will view your faculty evals and your peer evals. Next, I'm going to pull up nurse evals and patient satisfaction surveys, which are a little different. So nurse evaluations and patient satisfaction surveys are done via paper. We give these nurse evaluations to nurses in the ER, HEMONC, NICU, and PICU, as those are the more closed units and they work with you more closely, versus like the floor nurses may work with you and other residents from surgical programs and may have a hard time keeping your name straight and actually rate the wrong person. And so we want to prevent that. Most of these apply to the areas of professionalism and communication, and then they can rate you on a scale of 1 to 5 and leave any specific comments. These professionalism ones with the prof under it, if a nurse rates you as a 1 or a 2, this will have an impact on your professionalism score for the quarter, and I will go over that with you in a little bit. So the ones that have prof by it, referring to professionalism, are going to be important when it comes to professionalism score. Okay, I'm going to pull up the patient satisfaction survey next. I lost my train of thought there. Okay, so patient satisfaction scores are something that have become more and more important over the past 2 to 3 years within healthcare systems, and pretty much any physician in the community does receive, whether it's a star score or a star rating or some other method of a patient satisfaction survey. This is just something that I want you guys to get in the habit of thinking about. Certainly because you're picking who you're giving the survey to, and we'll go over the process in a second. I do realize this is flawed. I realize that you're going to give it to the families that you work closely with or that you get interacted in a good fashion with. But at the end of the day, it's really more to get you used to the process of being evaluated by family members and by patients. So this is what our survey looks like. And it's really asking you, the family, how did you treat their child? Did you listen to them? Did you treat them with respect? Did you use too many medical words? Did they feel comfortable asking you questions? Did they think you should have spent more time with them? Or did they hear you talking about their child in public, like an elevator, etc.? So obviously most of these, a yes is going to be good. However, if you use too many medical words or they heard you talking in public about their child, a yes would be bad. Certainly some families go down and click yes, and it's clear by the comments that they just loved you. And we recognize that that's because they didn't specifically read every single question, and you will not be penalized. But this is just something to have a gauge of how you interact with families. So next I'm going to show you the process of these surveys and what we expect. And so basically you have to have one patient satisfaction survey done per quarter, but we don't require them to be submitted until December 15th, 2 of them, and June 15th, 2 of them. This allows some wiggle room in case in a quarter you don't feel like you have a patient that you've interacted with or a family that you've interacted with that would be good to fill it out. So this does give you some wiggle room, but again, 2 by December 15th, 2 by June 15th, and we request that you get them done in a variety of settings. So how will this work? Once a quarter, at the beginning of the quarter, Kelly will put in your mailbox an envelope, the survey, and the instruction sheet. Read the instruction sheet and write in your name so that the family knows who it is. You will give the family the survey and an envelope. You will ask them to complete the survey, put it in the envelope, seal the envelope, and hand it back to you. You will then return the sealed envelope to the chiefs in their mailbox or in person, or to Kelly. The chiefs will get it to Kelly. Again, you have to have 2 submitted by December the 15th. So that is sort of the process. And again, 1 will be placed each quarter. There's also some blank ones placed in the lounge in case you lose yours, along with some blank envelopes so that you have them available when you need them. Again, you can ask someone in continuity clinic, on the wards, in the ER, any patient, any family, that's at your discretion. Okay. So next we're going to talk about kind of continuity clinics and conferences, and then our professionalism policy. So let me pull those up really quickly. Okay. In addition to the patient satisfaction surveys, we do require all of our pediatric interns to complete 2 observed H&Ps each year, and that's, I'm sorry, just in their intern year, and observed by a faculty member. And so you need to complete 1 by December 15th and your second one by June 15th, just like for your patient satisfaction survey due dates. And that's part of kind of your requirements for your intern year. It could be any faculty. It could be an ER faculty, your clinic faculty, your hospitalist faculty, but they must physically watch you do a full history and physical to evaluate you and provide feedback to you on that process. And then you submit this form, which is a very short 1-page form, to the chiefs or to Kelly for submission. And you can even scan it and email it to Kelly, however you prefer, but due dates of December 15th and June 15th. So that is the patient, the observed H&P. Now we're going to talk about your continuity clinic expectations for the year. As mandated by the ACGME, all residents must attend 36 clinics per year. We actually break that down into quarterly requirements. So by the end of Q1, so by the end of September, you must have attended 9 clinics. By the end of December, 18 clinics. By the end of March, 27 clinics. By the end of June, 36 clinics. If you reach your minimum requirement, you must still go to your clinics. You can't just skip clinic because you met your requirements. If you don't meet your minimum quarterly requirements, you do lose professionalism points, which we'll talk about shortly, and you could be assigned extra call. If you feel like you're not on track to meet your requirements, you could attend a makeup clinic by looking at the clinic calendar and seeing what dates have a low number of residents during a session. You must receive approval from your clinic faculty to attend that session, and they must know in advance. So the way to keep track of this is that the chiefs do keep up with these numbers on a monthly basis. You should be logging clinics every time you go, and they'll send out your numbers once a month so that you can keep track. They meet with me as a compliance committee once a quarter, so you'll have time to fix your deficiencies before they meet with me and before I see it, okay? So please stay on top of stuff monthly. Don't get behind in logging or you'll regret it, I promise. In terms of patient numbers, we do monitor your patient numbers. We sort of have goals that you see 3 patients per session, 4 patients per session, 5 patients per session as you progress through training, but you're not penalized for these numbers. It's really to help us monitor what you're seeing. Again, you will track these patients in a logging system on the ACGME website, which the chiefs and Kelly will show you how to do. Okay, and then I'm going to pull up our conference requirements next. So we have morning report and noon conference almost every single day. On Wednesdays, we have grand rounds in the mornings. So we have abundant conference opportunities each year, probably over 320. During that year, you must, as a first year, attend 175 conferences. And we monitor that on a quarterly basis. So 175 conferences divided by 4 is about 43 conferences per quarter. You must meet that minimum goal at the end of the quarter. Again, the chiefs will send you those numbers data once a month so you know how you stand and you can make sure you get caught up by the end of the quarter. If you do not meet your minimum quarterly goals, you will be assigned additional prep questions at a 1-to-2 ratio. So if you were supposed to attend 45 conferences by the end of quarter 1 and you attended 40, you would have to do 10 prep questions that the chiefs provided or had you make up. So 5 missed conferences times 2, 10 extra prep questions. Okay. As you progress through training, the number of conferences remains at 175 if you score below the national average on your in-training exam. However, if you score above the national average on your in-training exam as a second year or as a third year, you get to attend less conferences. So 150 for second years, 125 for third years, and that's based on that year's exam. So if you score above the national average as a PGY 1, and you would like to assume you're going to do the same the following year, then you can assume that your number is going to be 150. However, if you get your score back in October and it's actually below the national average, you may have to have some catch up. So I would recommend that you start your second year assuming you're going to have to get 175, and then if you get above the national average, it's like a little gift. Why do we do that? Didactics and conferences are an additional way to get you educational material and to help you prepare for your boards. On your in-training exam, if you're getting above the national average, you have a higher likelihood of passing that board exam on the first attempt than a resident who's scoring below the national average. So it's an extra incentive to study throughout training to get that in-training exam score higher, but it's also an extra push to those residents who maybe struggle on tests to get them the educational conferences that they need. It's not a punishment, it's really to push you guys to study and do better. So quarterly attendance, and we give you extra prep questions, and you lose professionalism points if you don't keep up with your conferences. The chiefs will go over this as they monitor compliance on a very frequent basis. So none of this will be a mystery, and you could always rewatch this video to review. Okay, so now that we've talked about evaluations, conference expectations, clinic expectations, H&Ps, patient satisfaction surveys, etc., I want to compile them all into this one overarching theme of professionalism. So professionalism as physicians, we regulate ourselves, meaning there's no real governing entity besides physician entities that regulate us. And we really are truly held to standards and have to hold ourselves to standards of professional behavior. Part of professionalism is our behavior and our treatment of others and our interactions with patients, staff, other providers, peers, colleagues, etc. And then part of professionalism is staying on top of our regulations and our requirements, because this is something that you'll have to do from here until the end of your career. I had to just today complete a timesheet for myself and do some compliance modules, 8 years out from residency, and I'm still doing these things. And if I don't, I get penalized from our chairman. And so and our program is trying to teach you guys good habits so that you go out there and you're successful and you can do the best you possibly can to take care of your patients. And so we have this professionalism score. I will say that this is the most confusing or intricate policy that I think we have. And I've worked to adapt it since becoming program director in 2017. And Dr. DeSalle really did a great job putting this together to help guide the residents. So let's spend more time going through this face-to-face virtually on June 22nd, but I just want to sort of outline it here for you so you know what it looks like. So each resident starts off each quarter with 100 professionalism points. Each quarter, you're given a professionalism score. That score may be 100, that score may be 90, that score may be 80. You get deducted points based on the following things. You must have satisfactory professionalism comments or scores from faculty, peers, students, and nurses. A score of 1 would get you minus points from faculty and peers, and only in the professionalism domains, not in clinical care. If you're having clinical care deficiencies, that's a different issue. Professionalism domains. Similar with nurses. Remember, we said professionalism domains. Patient evaluations need to be turned in per semester to meet your criteria, and they should be positive. Similarly, you must have satisfactory reports from unsolicited sources. So if anyone comes to us and complains about a professional incident, you will hear about it. We will counsel you on it, but we will likely need to deduct professionalism points depending on the event. You must appropriately attend the required number of clinics when assessed on a quarterly basis, the required number of conferences when assessed on a quarterly basis. If you don't, you lose your 10 points. And you must do your duty hours documentation monthly, as we discussed. Also, you must complete 20 prep questions per month. We don't penalize you until the quarterly mark. So if at the quarter 1 you have 60, you're good. If you have 59, you're deficient. 120, you're good. 120, 119, you're deficient. So again, I want you doing these monthly. Don't wait. You learn more when you don't do too many at once. 20 a month, the chiefs will be sending you that tracking tool, and you can keep track of your progress. If you're deficient in that or any other thing you're supposed to submit on an annual basis, you'll be docked 10 points. During your training, you are given 1 quarter per year to be a minus 20 or an 80 score, and you'll get a warning. So if you're a minus 30, a minus 40, a minus 20, for 1 quarter, you'll get a warning. But if in a second quarter that same year you get a minus 20 because you still can't get it together to do these things, then if you have 2 minus 20s or more, you will be reported to the Board of Pediatrics as unprofessional. That's a big deal to be on their report as unprofessional. And each year I have to submit whether you're competent clinically and whether you're competent professionally. So if I have to click no for professional based on this, then that certainly isn't something we want to happen. In your 3rd year of training, before you take your boards, as you graduate, I have to submit more questions than just that, but professionalism still remains. And if I have to click you as no for that 3rd year of training based on this, then you wouldn't be able to sit for your boards without an additional amount of time as a resident. That has never happened. A resident has before been reported as unprofessional based on 2 quarters of minus 20 or higher in their 2nd year. 2 residents, in fact, one about 4 years ago and one about 7 years ago. So it has happened, but it is rare. And so we have this mechanism in place. If you get a minus 20 warning, I will meet with you face-to-face, one-on-one. And I assure you that will prevent it from happening again. But if it happens again, then this is our policy to make sure we're addressing it. Okay, so you know it, this is like the most harsh policy, but a necessary one. And let's talk more about the details when we meet face-to-face for our question and answer session. The only other thing to note is that in addition to the point deduction, for some of these activities, you will be assigned additional call if you're deficient. And so that's listed there as well. In terms of the compliance meetings, I'm on the compliance committee, the chiefs, my associate program directors, and my coordinators. That's a committee that meets once a quarter. So we meet usually in October, January, April, and July. And the chiefs will let you know the day of the month, every month, that they'll be collecting compliance numbers and sending you data. So have it done by the deadline. If you're past the deadline and they've given you a clear deadline, then there's no excuse for deficiencies. We're all adults. We can all follow the rules. Okay. We just have 2 other things I want to touch on very briefly, and then we're done. So Along the lines of evaluation, professionalism, etc., our promotion criteria, pretty easy. To go from a PGY1 to a PGY2, you must meet your milestone ratings that are appropriate for an intern becoming a supervisor. So that level 2 to level 3 number that we talked about, and really be on par with your peers. You must take your step 3 before the end of your first year. And I'll say that again. You must take your step 3 before the end of your first year, period, or you cannot be promoted. And I'll tell you why in a second. You must participate in, to the fullest extent, all of your quality improvement curriculum as outlined by Dr. Palumbo. For PGY2s, similar milestone ratings need to be appropriate for your level of training. You must present a clinical case conference. You must pass your step 3. This is why you must take it in first year. If you do not pass it in first year, I need you to have enough time to take it twice in your second year to pass. If you do not pass it your second year, you cannot be promoted. You cannot even be licensed until you pass it. And that's not going to happen. I don't want that to be the case, but there have been times where people had to take leaves of absence because they did not pass their step 3 in time to be third-year residents, and they did not have a license. And then you must complete your quality improvement. And then finally, to graduate, same things. You have to present at a Grand Rounds, M&M, or Journal Club. And then you do have to have a minimum number of LPs, intubations, and deliveries, so 10 of each. So that is your criteria for promotion from one year to the next, and for graduation. Speaking of procedures, we do have a procedure policy that I'm going to pull up right now. So I want you to all do procedures, seek out procedures, take some ownership of doing that. We are really working to refine our procedure process over the coming years. It's, the hospital is building a simulation center, and it'll be easier to work towards that. And I really will love to have you guys' involvement for some resident-driven initiatives over the next few years to make some of these things accomplishable. However, in the meantime, keep a record of all of your procedures in the new innovations system, just like you're going to keep a record of all of your continuity clinic visits in the ACGME system. The chiefs and Kelly will go over this with you, how to track it. Do it as you get it. Please don't forget that you did it and forget to track. You want to keep up with these numbers. And you want to record each procedure and whether it was successful. We would recommend a minimum goal for first years to do 5 LPs and 5 intubation attempts, and then attend deliveries. We said we recommend a goal of 10 while you're on Well Baby Nursery, but if you have to get some of those during your NICU experience, that's appropriate too. You must have these to graduate. And then we also want you seeking out these procedures during your training. Okay. So that is our procedures policy. And then the final thing to show you, just so you remember that it's there, is our IEU policy / curriculum. Every resident receives 7 IEUs during their training. We really want you using those IEUs to further your career needs and goals to prepare you for fellowship or for your career. And so I would like for you to select your IEU that you're doing each month based on these tracks. If you're going into primary care, what should you be doing for your first year IEU? Here's what we recommend. What should you be doing for your second year IEUs? Here's what we recommend. When we say subspecialty, these are the suggested subspecialties based on general pediatricians and the community's recommendations, okay? Year 3, this is what we recommend, okay? Let's say you're going to be a hospitalist. Here's our recommendations. Let's say you're going to go into subspecialty fellowship. Well, we have that outlined for you too, based on the Council of Subspecialists across the country, fellowship directors. If you're going to go into AI, here's what they recommend you do prior to starting a fellowship. So this was built and revised truly with your career needs in mind, and I would encourage you guys to use this as you select your IEUs during your training. The chiefs will keep track of that and make sure you're doing that. This should be your guide. Okay, So that was a lot. My throat hurts from talking, and I am again thankful that you guys, were able to bear with me through that. And hopefully, this gives you a chance to see what's out there, to know what to expect, and to give you a chance to jot down any questions that we can talk through when we do meet face to face on June 22nd. I'm so excited to see you guys soon. I'm excited for graduation and the start of orientation, and to have you as part of our LSU Peds family. We're going to have a great 3 years. Thank you for trusting me to be your program director. I'm truly grateful to lead this program that I'm so passionate about, and I hope that you are just as passionate about it in the next few years as I am. So I will see you soon. Have a good 2 or 3 weeks. Stay safe. Enjoy your moves if you're moving, and yay! Think about what you want to do for a socially distanced social with me when you're here that week, and we will find something fun. Bye, guys.